All right, good evening, and thank you very much for joining the last session of Legendo in 2023. We started this in January this year, and with the exception of 1 month where we all were in Brussels at ESGE, we have run this journal club on the 6th of every month at 6 p.m. UK time. There have been some changes in the format, but generally speaking, the aim is to have one, sometimes two featured presenters of recent article published on endometriosis, presenting their own work. And that has worked quite well. We've had very good presenters and very good featured articles, and tonight is not an exception. Professor Zuppi very kindly agreed to join us, and I will present him properly in a minute. A couple of housekeeping. One is Legendo will continue into 2024. We already have the lineup until June or July. Avril will correct me, and therefore the same time, same format, one or two featured presenters. The team is expanding, but the current team, you can see, with the exception of Mikey, who's on the board meeting with BSGE, Avril, Bachi, Kyle Fleischer, Ben Mondelli, Mikey Adamczyk, they all do a great deal of work between sessions, selecting articles, inviting new presenters, sifting through what has been published. You can ask your questions, like always, in the Q&A box. We're going to have one short presentation from Kyle, and then we'll go to Professor Zuppi, and then some question and answers, and then we'll go back to the rest of the journal club. I would like to thank Karl Storz for its support, for running Legendo. We are going to continue our collaboration with Karl Storz, and this is a joint venture with European Endometriosis League, and we thank them for their support. We have not received any financial support, though, from either of those, at least not yet. So let's also, the final thing, which is perhaps the most important, is we have no conflict of interest with any of the products or the companies that we're presenting here in the articles. And the fact that we present an article by no means should mean that we support the content of the article. So we are merely presenting what the literature says, and we believe that these are articles that are worthy of attention. And that's why we want to listen to them and hear what's being done. Okay, with that, Kyle, please start the first article.
Grand, so thank you, Mr. Ghazali. So I'm presenting a follow-up study from an RCT looking at a specific adhesion barrier, which I have to say we do not receive funding for. We don't actually use this adhesion barrier, but I thought it was interesting in the context of endometriosis and post-operative adhesions. And this is published by a group from Tübingen in Germany in the Journal of Clinical Medicine this year. So this is the original RCT. The powder itself is made up of hydrophilic microparticles manufactured from a highly purified starch of plant-based origin. It works as both as a hemostatic agent, but also when crystalloid fluid is applied, it creates a gel layer, and reabsorption is approximately 7 days. In this study, severity and extent of adhesions were significantly reduced according to their measures, and the incidence of adhesion formation was also Reduced. So with this study, this was actually a 12-month follow-up of the original RCT. The initial intervention had 50 participants with 25 in each arm. 3 were lost to follow-up in the control arm and 2 in the intervention arm. It is this centre's practice to typically perform a 2-stage procedure for those with deep endometriosis, where the first is mainly getting a histological diagnosis, but also performing any intervention that may be based on symptoms as well as opportunity. So if they can excise all disease at that time, they do. The second procedure, which in this cohort was on average 6 to 8 weeks following the first, was to completely excise all disease. In the intervention group, the powder was applied to all areas of resection and dissection, whereas in the control group, only sodium chloride was applied. This study collected symptom scores as a baseline at different time intervals following the second procedure. Although the numbers are very small in this study, the intervention group had a significantly higher pregnancy rate compared to the control group, 7 out of 11 versus 3 out of 14 in a group of patients who had a pregnancy intention both before and following the procedure. The intervention group also showed a more pronounced improvement in cycle-independent pain and dysmenorrhea, which were the 2 subcategories with the highest preoperative scores and also the highest relevance to patients. It's very important to know that the sample size calculated for this study was to look at the adhesions, and therefore these secondary endpoints are actually underpowered. It's also important to know that the study did receive funding from the manufacturer, although no authors received direct remuneration. So this is an example of first and second look procedures. So the top 3 pictures were, so A and B is first surgery, and C is the relook. So that's where sodium chloride was used. Then D and E are the first look with the adhesion powder applied, and then F is the second look. So this is a kind of background of demographic info, and I've tried to highlight for those who are more familiar with Enzian that not only are the cohorts reasonably well matched, that actually this is maybe moderate disease, so disease that was deep but affecting the pelvic sidewalls, uterosacral ligaments without too much invasion of the rectovaginal space. And here's a representation of symptoms over time. So the top shows a graph for non-cyclical pain on the left and dyspareunia on the right. The bottom shows pain scores both prior to surgery and up to 12 months follow-up for different measures, with the intervention group on the left and the control group on the right, where the stars are significant, statistically significant differences. So to summarize, this small but interesting paper presents the results of this RCT for the specific barrier for dry field. The intervention group had a significantly higher pregnancy rate and improved pain scores compared to the control group. And the authors felt that the favorable outcomes were partly contributable to the intervention.
Okay, I think a few things come immediately to mind. One is I don't really understand the 2-stage procedure very well. And you can say it's a second look for research purposes, but I guess maybe the ethical approval wasn't forthcoming for that, and therefore they had to cut the procedure in 2. I don't know. I don't understand it very well.
So that's the 2 stages standard protocol for their center.
No, but that's the thing. When we talk about 2-stage procedures, we either are talking about the first stage, you deal with endometriomas and don't do any excision. If you're doing an excision, what's the second stage for? That I don't understand. But perhaps, you know, it needs a bit of a deeper dive. The other thing is, as far as I'm aware, for dry field is one of few different products in the market with exactly the same preparation. So it's just a difference in the bottle. But again, I may be wrong. I hope Ford Dryfield doesn't come back to me and sue me or something. So interesting to hear a massive difference in pregnancy rates, but whether or not it has any meaning in a group of 25 patients in each arm, I very much doubt it. Again, you know, the devil will be in the detail. Okay, so we ran a poll asking people what adhesion barriers people use. 26% use both powders and gels. 4% uses powder only. 13% uses gels only, and 17% use powder, but not with the intention of adhesion prevention, and 39% don't use any adhesion prevention. Okay, that is also interesting. All right, let me introduce Professor Enrico Zuppi from University of Siena. If you have paid attention to endometriosis at all, you will know Professor Zuppi. You know, the number of publications that he has produced and his team has produced is just phenomenal. And I remember, I don't want to say, Enrico, that you're older than me, but I remember when I was training, I was reading.
You can underline that.
But seriously, I read your articles growing up, so you know this is really a pleasure for me and an honor, and thank you very much for accepting our invitation and coming to our meeting. What really caught our eye was the article that you recently published that you're going to present to us. Is really one of the most challenging topics in our field, and opinions are divided. And as I'm sure you'll agree, there isn't a huge amount of data on it, so a lot of it will need to be again maybe level 3, level 4 evidence. So it really, when we're dealing with something like that, then a group approach to consensus approach, I think, would be very helpful. So I was really interested in reading your paper. I won't take up more of the time. I know that you need to leave right after the presentation, so please, the stage is yours, Enrico.
Thank you very much, Shane. It's a pleasure to see you and to be here. I will try to
We can see your screen. You're on mute, Enrico. Yeah.
Are you able to see
Yes.
my screen? Yes.
Yes, we can see
Okay,
you.
thank you again.
And
Thank you. Thank you also for your presentation. This is an important point in our opinion. I'm talking on the name of this group we created 12 years ago in Italy. The ETIC is the acronym, Endometriosis Treatment Italian Club. And adolescents, thanking overall one of my young colleagues, that is Francesco Martire, is growing up as one of the most important points, because as you know very well, and we will see in our slides, how important it is to reduce the time of a diagnosis and to become really earlier in the diagnostic process of endometriosis. And good. These are the topics of this presentation: the prevalence of disease, the early, I repeat, non-invasive diagnosis, and the role of medical and surgical treatment when and if is possible. The background is very well known to every one of you. Endometriosis, we are talking about the 10% of adult women worldwide, and the delay in endometriosis diagnosis is very well known. The prevalence in adolescents is currently unknown, but now, after so many years, we described in 2014, starting from here, from Siena, that in a group of young patients between 18 and 29 years old, we had results around 34% of endometriosis, but overall adenomyosis. And this is an important point because we have to clarify the presence of these two pathologies, I mean, the same pathologies in young women. Painful symptoms are often underestimated despite its impact of quality of life, and often endometriosis and adenomyosis, I mentioned before, are concomitant. So this is what happens in women with this kind of symptoms and this kind of pathologies. The quality of life is the most important thing, especially in young women, but not only in young women. So we have to relate endometriosis with the reduction of quality of life, and also pain symptoms, impact on daily life, and physical functioning are different. 16 to 61% experience difficulties with mobility, daily activities, and self-care. And from 19 to 48% of women experienced a reduction in social life. In 23 to 71% of women, household and housekeeping activities are affected. This is a paper a little bit old, but is still a reality, and we have to consider this point because this is the first explanation around our activity to detect earlier and to treat, when possible, this kind of pathology. I would love to remove this one. No. Okay. Education. Some women affected by endometriosis leave education before the completion of the women miss an average of 7.5 hours of work per week and 19 days per year. 64 women have a reduction of efficiency level of work. These are numbers that need a reflection, because we can consider all different aspects, and we can discuss, if you want, after the presentation about that. But the point is, we have, starting from 7 till 9 years of delay in a diagnosis of something that we, at this point, even thanking the organization as LEJENDO or others worldwide, we have to detect earlier what happens in young women. And overall, we have to underline how important is an early non-invasive diagnosis. We start usually with the symptoms. Overall, the severe dysmenorrhea, abnormal uterine bleeding, and resistant also to empiric medical treatment, painkillers that are aspecific, as you know, and so on. The physical examination, even if in young women is not so easy, is important, is absolutely important, and we have to consider that. And an increase in the prevalence of endometriosis and adenomyosis in the last years was observed with an improvement of non-invasive diagnosis, because at this point we don't have to wait for the sometimes requested histological approach. We need to detect through clinical appearance and non-invasive tools like transvaginal or transrectal, we will see, ultrasound and MRI. Okay. Talking about imaging, MRI and transvaginal ultrasound are considered both to be probably the best tool for a non-invasive diagnosis of this pathology. Transvaginal ultrasound is probably to be considered the first line imaging technique in the assessment of different types of endometriosis. But we know we have different situations in different countries, and not always is very well known the detection by transvaginal ultrasound. In our opinion, we can overlap transvaginal ultrasound and MRI to detect in a non-invasive method this pathology. In my country, in our country, transvaginal ultrasound or transrectal sonography, when transvaginal ultrasound is not possible to perform, is absolutely good to obtain a diagnosis or a real suspicion able to suggest some medical, I have to talk about only medical approach in our therapeutic treatment. These are two recent papers we published on this topic. The aim of this one that was published on 2020 on fertility and sterility was to assess the prevalence and the ultrasound features of pelvic endometriosis and adenomyosis in adolescents, 12 to 20 years old. These was the prevalence, and you can summarize by yourself the numbers without a repetition. And this is important to consider the numbers to underline how important is the early diagnosis in young women. And these are the symptoms related to this population, and in presence of these symptoms, the prevalence of endometriosis and adenomyosis increased, and we have to underline that dysmenorrhea and also the evaluation of some other panels like hemoglobin are underestimated, and this is important because it's a way to obtain an earlier diagnosis. Another paper was this, and the aim was to assess the prevalence and ultrasound features of pelvic endometriosis and adenomyosis in women with severe dysmenorrhea, and these are the results, the characteristic first of patients, and you will see also what we found using ultrasound scan in terms of number, and also which was the difference of progression of the disease over the time, considering 12.8% aged 12 to 16 through the 42.6% aged 21 to 25. And also design we found are strictly related to the appearance of endometriosis, and also the degree, the level of endometriosis that was it is important to underline our uterosacral ligaments was most frequent, the localization, the most common localization of the posterior endometriosis. Another paper published in 2023 underlined that following our paper, the results are the same. The group, the population is a little bit smaller, but the results were the same. And the prevalence rate of endometriosis were 39.3% and 11.5% respectively. This is related to the age of the different group of patients. So the role of medical therapy, we know very well the role of medical therapy, but this is the only way we can propose a therapy in adolescent patient with obtained symptomatic relief of pain, suppression of the progression of the disease, the potential progression of the disease, and protection of the future fertility. There are also the ESHRE guidelines that advises clinicians treating women with endometriosis to prescribe hormonal contraceptives or progestins to reduce the endometriosis-associated pain. That is important. But in my opinion, out of this different papers, we have to be quiet in talking about surgical treatment in young people. Just in case of symptoms related to an obstruction, we have to consider the surgical approach, because we know that after the surgical approach, even in young people, we have to consider to use the medical treatment. So first of all, we have to start with medical treatment. Then, if the medical treatment doesn't work in this group of patients, we can consider quietly the possibility of a surgical treatment. This is an algorithm we organized, and you can read in this algorithm that are the way we can follow using medical therapy or what? The improvement of symptoms, we consider that to go to a right follow-up, as well as in case of no benefits and worsening of symptoms, we can consider surgery, and then we can switch on a follow-up. Overall, in conclusion, a strong association between adenomyosis and endometriosis, even in adolescent women. Isolated small sign of disease increases over time, and early non-invasive diagnosis and adequate management could be useful to improve the quality of life of these young women, to reduce the progression of the disease, and to counsel respect the fertility impairment of these patients. Thank you.
Thank you very much, Erica. Really interesting topic and very, very difficult decision making. So we put a poll up. The question was, do you have a lower age limit for operating in an adolescent presumed diagnosed with endometriosis? So you do an ultrasound scan, you find something, and what is the age? And people have responded. 74% say 16 years old, as in they wouldn't operate on anyone lower than 16 years old. Some have said 15, some have said 13, some have said younger than 12, 7%. But the most likely, the most common answer was people won't operate on girls younger than 16 years old. Do you have a lower age limit, Enrico? Do you think there should be a lower age limit?
Listen to me. Thank you for this question. That is really interesting. In my personal opinion, and also looking at the literature, we have to reduce as much as possible a surgical contact in adolescent women. In my opinion, we have to try to avoid this surgical approach because, as you probably remember, a few years ago, not so few, but 10 years ago, the American Journal published a paper in which they discussed about a patient operated at the age of 30, 31, 11 times. And looking at this kind of pathology, that is a benign pathology, but very, 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 very chronic disease, we have to think about that if we decide to operate because the young 16 years old women doesn't respond to medical therapy, immediately we suggest a surgical approach. Is possible that between this data and the day of the decision to have a pregnancy will be reoperated many times. And in my opinion, it's more important to detect where are these localization of endometriosis, which is the exact data, the exact age of the patient, and to avoid as much as possible, with exception of obstruction related to the lesion. I mean, bowel or ureteral obstruction, in which we have to make an intervention, even in women 16 years old. We have to avoid that. We have to avoid that.
And do you think that if in a 15-year-old, for whatever reason, surgery is decided, let's imagine that there is an indication and she needs it. Do you think that any endometriosis surgeon could operate on them, or do you think a further training and experience in looking after adolescent endometriosis is important?
This is another good point. The problem is to have the chance to involve also their mothers, because a young woman, even less than 16 years old, is not able to understand everything. It's very rare, in my experience, to have a so large diffusion of endometriosis at this age. You know that there are the possibility to have also adenomyosis is very rare at that age. But also the different lesions are often isolated. And so is very rare the need of a surgical approach. This is my point of view. And this is also the way to avoid the IVF programs for sure after these different surgical steps.
Enrico, I certainly think that even if surgery is done, it's very important that the first surgery is the best surgery, you know, and therefore, if we are operating, and that should be the case for everyone, but especially in a young woman, I think if you're operating, you really need to operate with the view that this is going to be the last operation. You're talking about 11 operations, Enrico. My record is 60. six
Yeah.
zero operations on the same, not me, I haven't done those operations.
But 59 were wrong. That's my opinion.
Yeah, that's
The
correct.
decisions were
And
wrong.
only today, I'm talking about today's clinic, I saw a lady who at the age of 20 has already had 4 laparoscopies, and unfortunately her ovary was removed at the last operation, and she was told that your ovary was completely destroyed by the disease, whatever that means. Anyway, so I know that Erica,
I have to
yes,
say
you have to go, and I'm very grateful for your time. Thank you very much. We're going to continue that discussion in a minute, but first, let's say goodbye to you and thank you again.
Thank you.
Erica. Okay.
Thank you very much, Shane. Thank you.
Bye-bye.
Thank you.
Bye.
Bye.
Okay, so before we move on, let me ask Alan. Alan, what do you think? Do you think that there should be an age limit in operating on endometriosis, and lower age limit?
I think whatever kind of age limit we're discussing right now, things are going to change in the coming years. Because if you look at the social habits, teenagers are getting their periods earlier and earlier. So, of course, the surgery should be, let's say, the last resort. But I think each one of us had situations where we had to do surgery on a 15-year-old patient because the contraceptives were not helping. 2 weeks ago, I saw a patient with massive symptoms, and she was only 13. Her first period was with 10. So I think any age limit we would discuss is going to go lower and lower as time goes by. So situations like this we're going to encounter them more and more frequently.
Okay, thank you. So let's go through some of the questions. Ahmet Kale, my friend from Turkey. First of all, Ahmet, thank you very much. You always ask very good questions, and you're always a very active participant. And I noticed, by the way, that my friends from Turkey who are going to be featured presenter, I think in early next year, are always here, and I'm very grateful. I wish we could change things in a way that I can actually have more on the panel and we can have a better discussion. Professor Oral, Tanush Usta. Anyway, going to your question, Ahmet, what is your first-line medical therapy choice, oral contraceptive, progestin, and why? And my second question is, do you use GnRH therapy as second-line option in adolescents? To be honest, Ahmet, I don't have a good answer for your first question. I normally use either progesterone-only pill or the combined pill. I tend to start with progesterone-only pills. I don't have a very good reason for that, but I will start with that and see if we can win stopping the periods altogether. GnRH analogs, I generally don't use GnRH analogs in the adolescent. Again, I don't even use it in older women very often, very, very rarely. Melissa, let me, Engin, I don't know if you will be able to come join us. Shall I bring you up? I don't know if Avril can do that. Maybe you can help answering some of these questions. Avril, can you please bring Professor Oral?
All right, I will try. Let me.
If he's happy to. Do you have an age cutoff to start prescribing Dynagest in adolescent? Is there a time period you limit use of Dynagest in this group due to bone density outcome? Alan, do you have an answer to that?
my recommendation would be to avoid the use of mini pills of progestins in teenagers, and I think we should prefer some combined oral contraceptives. And if we decide to go for hormonal IUD, it should be one that's low dose.
Engin, thank you for joining us. You're on mute, but it would be good if you can take this next question. Do you operate or excise isolated ovarian endometrioma solely due to pain? Does an isolated endometrioma that cause pain, or the pain is usually due to concomitant DIE lesions? I don't know if Engin can hear us. He's on mute. Maybe I will answer this while Engin unmutes. Well, first of all, an isolated ovarian endometrioma is very rare. We very rarely see endometriomas without deep endometriosis, and nobody knows which one is causing the pain. But if you ask me, I would say it makes a lot more sense that it's a combination. And yes, it's more likely that it's the actual deep endometriotic lesion, and therefore, if you're operating, you operate and deal with both of them, not just one of them. What's the point in delaying the surgery if the disease is progressing and will negatively impact your quality of life? So that goes to the heart of the question of decision making and what's the best thing to do. First of all, the disease doesn't always progress. So a recent study that we, in fact, presented a couple of months ago showed that in up to 70% of patients, the disease will either regress or remains the same. I agree with you that if we are going to do surgery, in my books, coming up with arbitrary age limits is not the right thing to do. The fact that somebody is younger shouldn't mean that they should receive suboptimal treatment. And I believe in the minimum required force to be applied. If you can win with simple measures, you win with simple measures. If you need to do surgery, do surgery, even if the person is quite young. So let's, the time flies. We only have 15 minutes to finish the rest of the presentations. I think this one is yours, Ben.
Yeah. So my first presentation, my first paper that I've chosen is this really nice paper from Ludovica Verrelli and the Horace Roman team. It looks at the difference in terms of cost, outcomes, time in theater between robotic-assisted surgery and laparoscopic surgery. So we can go on the next slide. It was published very recently, only the last month in JMIG. So it's a cohort comparative study where 175 patients were symptomatic for endometriosis and underwent surgery for deep endometriosis between March 21 and August 22. So for the robotic assisted, they use the Da Vinci X, and for the laparoscopy, the Karl Storz laparoscopic stack. And the way they were chosen, either one or the other list, it was quite random in a way. So there wasn't a big bias. So the only surgeon that was operating on these 175 patients was Horace Roman. He had 2 full lists per week, and one list is a robotic list. The other one is a laparoscopic list. And patients with severe endometriosis requiring this surgery were allocated either to the robotic or to the laparoscopic one, depending on their arrival in the hospital. So we can go next slide. So what did they look when they were doing this paper? They look at the total surgical time that was taking them to do the operation itself, the total surgical occupation room of a theater, and then look at the time in hospital in general, so the hospitalization. They look at the post-op complications. They look at the cost for each surgery based on the total number, on the total cost of the consumable instruments, the trocars. So they didn't include in the cost of this paper, the extra theater time, for example, and they didn't include, for example, the cost of a robot itself. These slides show you a little bit the demographic of the patients in the table 1, and in the table 3, as you can see, it shows you the outcomes. So significant statistical difference has been shown here in the total surgical room occupancy time. So as you can see here, there is almost 1 extra hour required for the robotic assisted approach, with 203 minutes in comparison with the laparoscopic approach that was 151 minutes. The operating time itself is again almost 1 hour difference between the robotic approach and the laparoscopic approach, with 105 minutes versus 150 minutes. The outcomes themselves, there wasn't any difference between the two approaches. So you can see the blood loss is exactly the same. Hospitalization very similar, with 2.5 days for the laparoscopy and 3 days for the robotic approach. Complications, once again, very similar, and in terms of reintervention and surgical revisions for fistulas, once again, very, very similar. So 10 patients surgical revisions with a laparoscopic approach, and 9 patients with a robotic assisted one. Can go on the next slide. And the other significant difference between the robot and the laparoscopy, which was shown in this paper, was the cost of the consumables. So as you can see, the robotic surgery for colorectal resection, for surgery where colorectal resection was performed, they were 14% more expensive. So with the laparoscopic approach, cost was around 2,600 euros in comparison with the 2,950 euros of a robotic surgery. Even higher difference was when a disc resection was performed, with 1,500 euros roughly with a laparoscopic surgery and 1,900 euros roughly for a robotic surgery. So a 25% extra cost for the robotic surgery. So what this paper shows that there is feasibility in the robotic assisted treatment of severe endometriosis, although there is an extra 20% average cost. The authors highlight the weakness of this study, which is the lack of randomization and the heterogeneity of endometriosis location. And the authors highlight how the robot has great advantages in terms of like a better visualization, better precision, and probably, and I agree with this, the next step would be, with the next papers, to identify the specific indication for the robotic surgery, where these technical advantages given by the robot show some objective improvements in patients' outcomes. So, yeah. I think you're muted, Mr. Casale.
Thank you very much, Ben. We'll go through the questions in the end if there's time. Kyle.
Grant, so next I'm presenting a study that looks at pregnancy rate following surgery for endometriosis, and the authors have tried to assess this and make recommendations for when to refer for assisted reproductive therapy. So this was published recently in the International Journal of Gynecology by a group from Frankfurt. So this study is a retrospective analysis conducted at this endometriosis center involving long-term follow-up of their cohort who underwent a laparoscopic surgery for endometriosis. The study enrolled women who were unable to conceive for at least 12 months with a pregnancy intention during the study period. The study collected data on the cumulative pregnancy rates, the presence of endometriosis recurrence within the study period, and the use of assisted reproductive therapy after said recurrence. The study also considered factors such as previous procedures, the impact of complete endometriosis excision, and normalization of anatomy. So it used uni and multivariate regression analysis, and was performed to examine the factors influencing the time until pregnancy after surgery. Surgery was defined as complete excision of visible disease, with restoration of the anatomy being one of the main surgical goals. And they felt, based on the notes, that anatomy was restored in 91% of the study group. Results are noted here, and I'll go into a bit more depth in the following slides. But excision of disease appeared to improve time to pregnancy, whereas previous surgery and partner subfertility had a negative influence on time to pregnancy, and I guess that would be expected. And based on these results, the authors have provided the following recommendations about when to wait before referring for assisted reproductive therapy. So in higher stage ASRM, and it's important to say that although ASRM has its flaws, the authors did use the revised ASRM classification here. So stage 3 and 4, they said refer no longer than 12 months after surgery. And for lower stage, so 1 and 2, consider up to 24 months. So this is their flow chart of how they reached their study population, which included 102 patients. These are the results for pregnancy rates. They've looked at were there any kind of influencing factors, and it appears that there wasn't a significant difference in age in this cohort between pregnancy and no pregnancy, as well as other background data. Obviously, there was a difference in number of years of infertility. On the left, there's the cumulative pregnancy rates, which maxed at 69.8%, and then also the numbers achieving pregnancy through either spontaneous pregnancy or with ART according to stage of ASRM. And then this final slide is a table that presents the time to pregnancy for both spontaneous and assisted conception according to ASRM stage. And as you can see, individuals with lower ASRM had greater potential to achieve both spontaneous and assisted conception later following surgery compared to those with higher stage disease. So based on these findings, the authors had recommended waiting no longer than 12 months to achieve spontaneous pregnancy for those with stage 3 and 4 RASRM classification. And the highest rate, and just on this table, the highest reached cumulative pregnancy values are shown in bold. So the authors acknowledge that the factors contributing to subfertility with regards to endometriosis are complex, but as a simple guide, this is what they went for.
It's I have to say I feel frustrated by the way that we are limited in our research methodology in surgery in general, because you know, studies like this are very valuable, but the numbers are small. We don't really understand from our ASRM the severity of the disease. It's in my opinion, and I'm biased, but ASRM is, in my opinion, almost pointless to use in these settings. And again, the devil is in the detail, looking at exactly how you know, those arbitrary numbers are not arbitrary, but those numbers and the recommendations are, because each person is different. Just lumping them based on severity of the disease and coming up with a flow chart, in my opinion, is too simplistic. Let's go through the final study, and then we'll have probably 2 or 3 minutes to go through. There are a few questions that we need to address.
So the final study is about percutaneous imaging guided cryoablation of endometriosis scar in the anterior abdominal wall, and is from Charlotte Geoffroy from Strasbourg and their team, and was published recently again in June of 2023. And I found this paper actually interesting because I was telling the rest of the team, I had 2 patients in the last 3-4 weeks that I saw in clinic with this endometriotic nodule in the anterior abdominal wall, and without any other symptoms apart from painful nodule. So this paper was done, like I said, in Strasbourg between 2020 and 2022, and involved 29 patients which were treated with cryoablation. Yeah, we can go next slides. So they collected data with the symptoms prior to cryoablation, the type of treatments that this patient had in between the diagnosis of a nodule and the cryoablation itself. They look at the details of the procedure itself, the type of anesthesia, how long it took, if there was any complication, the overnight stay, and ultimately they had a look how the pain has improved following the cryoablation and the difference in size of a nodule between before and after the cryoablation itself. Yeah, we can go to the next slide. So as you can see here is some demographics. So you see 28 out of 29 patients had a cesarean section, and a little bit below this line, you can see the other type of surgery that these patients had before the cryoablation. In terms of treatment that this patient had between the diagnosis of a nodule and the cryoablation, 12 patients, so 41% of patients had oral progestins, and 1 patient had surgery. 16 patients, so 55% of them didn't have any form of treatment. In terms of size of a nodule, the mean, the average was 11 centimeters cubic. So the volume was 11 centimeter, and the location of a nodule, 50% of the times was deep, in the muscle and rectal sheath, and 20 and 30% respectively was more superficial and intermediate in terms of depth. We can go on next slides. And in these slides, in the second table, you can see some more information about how the cryoablation was performed. Pretty much the same number had done either under general anesthetic or under local and sedation. In the other table, in the table number 4, you can see the difference between before and after. So you can see the visual analog scale in terms of pain. So the orange line is before the procedure and the blue line is after the procedure. And even the size of a nodule, there is such a significant reduction in the size of a nodule itself. Complications, we only had 1 complication, which was a frostbite that healed with conservative treatment and dressing within 2 weeks. So if you will go a little bit more in details about how the symptoms have improved or not after this type of procedure, you can see that 62% of patients had a complete pain relief after 1 month, and 72 after 6 months. Of the patients that did have some symptoms which were persistent, they had a follow-up MRI, and you can see 4 of them, they had confirmed MRI persistent or recurrence disease, so they had some enhancing nodule on the MRI, and 4 of the other 4, so other 13%, didn't have any enhancing nodule, and the nodule was smaller in size, and it was like highlighted that that kind of nodule was scarring following the cryoablation. Of these patients, most of them, they still did have a significant improvement of their symptoms, so they didn't seek for any further treatment, except 1 which is booked for a second cryoablation. In terms of reduction of the size of a nodule, 14 patients had a MRI 6 months following the cryoablation, and the reduction in size of a nodule is very significant. It went from 11, like we said before, to 1 centimeter square. Yes, this was the paper. I think it's interesting.
Yes, I think it's interesting as well, but I was looking at this before the meeting, and I was thinking, if you're putting someone to sleep in 50% of the patients, and the nodule is right in front of you, you know, why not cut it away and know that the nodule is out? And we all are a bit sensitive about the word ablation, because particularly for this type of endometriosis, you have seen then when we operate on these women, it's like a stone. The nodule is a dirty white and black and brown stone. Do we really think that cryoablation sorts out all of that nodule? And 6 months, I think 6 months is far too short.
Yeah, and this is one of the limitations of the paper.
Maybe they will tell us with a bit of a longer follow-up. But thank you very much, both Ben and Kyle. Let's go through the questions quickly. Yes, Tanesh says we need to learn more about post-operative differences between the two methods, and there are some studies looking at the difference between robotic and laparoscopic in post-op recovery. It would be good, Tanesh, if you can write in the Q&A if in your experience there is a difference. I have to say I haven't found personally that it's different. I mean, after all, it's you normally have a little bit of a bigger port size, and whether or not the fact that the robot can calculate the pressure on the abdominal wall and the effect that has makes a big difference is another matter, but maybe there is. My other colleagues feel that there is a big difference in their practice. It's just that I don't know if there has been a big difference in my practice. Roya, hi Roya. Roya was one of my fellows in Iran, who's now in Canada. Roya is asking what is the placement of the trocar. People do it differently, but in our center, we put, when we use 4 arms, we put them all in the same line over the umbilical level. I use 1 left robotic port and 2 right robotic ports, and then if we need an assistant port, we'll put it between the robotic port and the umbilical camera port. Tanner says that I have observed post-operative recovery is faster in robotic surgery. That's interesting. Thanks, Tanner. Alvaro is asking, how do you counsel patients seeking surgical treatment with ultrasound findings of only adenomyosis and perhaps suspected peritoneal endometriosis? Well, first of all, it depends on the age. Have they completed their family? If you have a confirmed adenomyosis in somebody who has completed their family, then it makes sense to talk about a hysterectomy. And it also depends on the type of symptoms. What's the major issue? For example, is heavy menstrual bleeding a problem as well that we're trying to solve, or is it just pain? And if it is pain, is it more of a central pain? Is it a more crampy pain or sharp pain? Is dyschezia a big problem? But generally speaking, it's difficult to differentiate between symptoms coming from adenomyosis and symptoms coming from endometriosis. If somebody haven't completed their family, I would still consider excision of endometriosis and preserving the uterus, with the understanding that it may not solve all the problems. So Sarah Merzuki says, if they have large endometriomas, would surgery be a better option than a better option, as the endometriosis would affect the ovarian cortex and the disease is a progressive process? Well, that is a very complex topic in itself. What to do with endometriomas and how to consider the risk of progression of the disease, and also the risk of the injury that the presence of endometrioma can cause on the endometrioma if we didn't do anything about it, with the risk that the surgery itself poses to that endometrioma and reducing the ovarian reserve. Very complex, and we deal with endometriomas in 6 different ways. Do nothing, just drain, alcohol sclerotherapy, plasma jet, excision, and an oophorectomy, if somebody doesn't meet the ovary. And deciding between which approach to use, of course, will depend on the person and each individual patient. So I would like to thank you all for attending this, and thank you for being supporter of Legendo. This is the last session in 2023, so I wish you all a great time over the holiday periods if you live in a place that has a holiday period over the Christmas time. And we look forward to seeing you on the 6th of January. Hopefully my operation on the 6th will go well. We have a really big operation planned for the 6th of January, but I will hope to see you on the 6th. I think we have our friend Olivier Donnet talking about shave of rectovaginal endometriosis. I'm sure that is going to create lots of lively discussions. Is there anything else, Avril, Kyle, Ben, Alan, that I'm forgetting before I close?
Happy New Year.
Happy New Year to everyone.
Thank you everyone for
Okay.
joining us.